Yeah. Good evening, good afternoon, good morning, everyone, and Happy New Year. My name is Wilson Sabyumva. I am the Global Director for Education and Training for TORG. I'm very happy to welcome you all in this very first webinar this year, which we are going to discuss on awareness under anesthesia. Very happy also to welcome training and education committee members. Very happy to welcome the CEO and the founder of TORG. We are happy to have her today. So without taking much, let me welcome Mr. Dani to introduce our speaker of today. Our today's speaker is called Dr. Justin Hagumimana. So let's ask Dani to welcome him. Thank you very much and wish you a good and fruitful session. Thank you. Welcome, Dani.
Thank you very much, Wilson. Good evening to all. And I'm happy for today's session. It has been a while no meet and no sessions like this. So I'm very happy that we are resuming and we're coming back in 2025. I hope this year is going to be a great year for us and TORG. So, ladies and gentlemen, please join us to welcome Dr. Justin Hagumimana. It's my pleasure to introduce our esteemed speaker for today's webinar, organized by the TORG-RW chapter. Please join me in welcoming Dr. Justin Hagumimana. So he is a highly skilled anesthesiologist at Inkuru Nziza Orthopedic Specialized Hospital in Kigali, Rwanda. Dr. Justin also served as education and training coordinator for the TORG-RW chapter, where he plays a pivotal role for advancing knowledge and skilled in preoperative care across the region. Today's webinar, titled Awareness Under Anesthesia, Understanding, Preventing, and Managing Intraoperative Awareness. We draw on Dr. Justin's extensive expertise and commitment to enhancing patient safety in the operating room. We are excited to have him with us and look forward to an engaging and insightful session. Kindly join me to welcome Dr. Justin for this webinar of today. So, Dr. Justin, the floor is yours to see an insightful webinar that you're going to give us. So, Dr. Justin, you're most welcome to start with the presentation.
Good morning, good afternoon, and good evening, ladies and gentlemen. Can you hear me?
Sure, we can hear
We can hear you.
Yes, we can hear you. Thank you.
Okay.
Hearing you.
Happy New Year, everyone. I take this pleasure to discuss with you. It seems to be an uncommonly discussed topic. So today's topic, as Dani and Wilson have introduced it, we are going to discuss about awareness under anesthesia. Okay. So it's like wake up during surgery, especially when the patient has been given a general anesthesia. I would like to start by a clear question. Awareness under anesthesia, as the previous picture can describe to everyone, it's waking up during surgery when the surgery is not yet concluded. So awareness under anesthesia is most common in cesarean section, in general anesthesia, surgery in polytrauma, cardiac surgery, laparoscopic cholecystectomy. Let's keep wondering on this question. Just one moment in the presentation to try to answer on this question. Meanwhile, if there is anyone who can guess where awareness or waking up during surgery is most common, provide the answer in the comment section while we keep discussing. So let's be a little bit faster. We are going to remind ourselves on the concept of anesthesia. The word anesthesia comes from a Greek word, and aesthesia, which means without sensation, without pain. Of course, anesthesia is a continuum whereby consciousness, recall, and reflexes, both somatic and autonomic, are gradually lost to enhance a safe surgery. Let's again remind ourselves about the memory. A memory, in simple terms, is the faculty by which the brain stores information. Medial temporal lobe is the mostly responsible for storage of information for our memory. Of course, we all know that there is a short-term memory and long-term memory. A short-term memory is it takes seconds to hours, while the long-term memory, it's about weeks to years. And we start everything that takes place in our memory, start with a short-term memory, which takes structural changes, involves structural changes to be transformed into a long-term memory. These terms will help us to describe more our topics. And these things take place in the amygdala and the hippocampus to create long-term memory. And if, for example, a patient or a client has a conscious perception of surgery, this will be in his part of short-term memory because it's about seconds to hours. So we'll see how to prevent this short-term memory to be transformed into long-term memory so that the patient can keep this in his memory. Thank you. Awareness under anesthesia or accidental awareness during surgery is defined as a post-operative recall of events occurring during general anesthesia. As we can see on this structure, this is the brain. We are providing analgesia, which means pain control. We are giving muscle relaxation to make the surgeon comfortable, much more comfortable for some specific surgeries, for example, bowel surgeries or muscles where the surgeon needs muscle relaxation. And amnesia or recall of the events. When the patient had not gained the full unconsciousness or amnesia, that's when we call it accidental awareness during general anesthesia, or simply awareness during general anesthesia. This is what kind of simple definition I can provide. Awareness during anesthesia generally occurs when there is imbalance between the depth of anesthesia and the stimulus which a patient is exposed to. In a surgery performed under local or regional anesthesia, this may be deliberate although there should not be awareness of anesthesia of the anesthetized region. Of course, the patient under local or regional anesthesia will be aware that the surgery is taking place, but will not remember the pain. Maybe if I can say, the numbered parts, you will not be aware of the pain that took. You will not get that pain of the numbered parts or the anesthetized part if it's a regional anesthesia. Other examples where awareness can be deliberate, it's like surgery that involves a wake-up test. For example, in King Faisal Hospital, Kigali, Rwanda, where we do spine surgeries or other kind of neurosurgery, in order, if we are not having sophisticated monitors like motor evoked potential, we can do a wake-up test. Of course, in that particular point, the patient will be aware of some events, can recall some voices, conversations, and a feeling of the tube in situ in the windpipe. About incidents, the awareness under anesthesia may be experienced by 1 to 2 patients in 1,000 subjects who receive general anesthesia. This is approximately 0.1 to 0.2%. When surgery is done in trauma cases, those are patients who are bleeding, those are patients who are critically sick, those are patients who are hemodynamically unstable. Sometimes the incidence of awareness has been reported to be higher, about 11 to 43%. This is a very high number. Cardiac surgery, especially when the patient goes to heart pump, heart-lung machine or cardiopulmonary pump, or other events where the patients may need to balance anesthesia and the hemodynamics of the patient, the incidence in cardiac surgery is 1.1 to 1.5. In cesarean deliveries under general anesthesia, it's 0.4%. Lucky enough, in developed countries, general anesthesia is being abolished to be used in surgeries of cesarean deliveries. Among the contributing factor, I see Ahmed has raised the hand. Okay. Can I hear you from you, Ahmed? You raised the hand.
Sorry, you can continue presentation. We'll have the time for Q&A. So you can present, then we'll ask questions after. Thank you.
Okay, thank you so much. Please kindly note down your questions. We have a particular session for that. Thank you. If I can roughly say, among 44% of the events, awareness was felt to due to low inspired volatile agents concentration or inadequate hypnosis, mainly due to low minimum alveolar concentration of inhalation anesthesia or wrong intravenous inhalation interval. If I can a little bit explain on this long intravenous inhalation interval, when we are inducing the patient to sleep, we give IV medication. And then to give the IV medication, then later we turn on the inhalation gas. In that particular time, the concentration of the inhalation takes some time, some minutes, depending on the status of the patient, the age, and the cardiac output, it may take some time to get to go above the mark aware. So in that particular time, the patient can still have awareness. Among 40% of the cases, maybe a drug error. This is most common in settings where they use thiopental, which is no longer being used, but a drug error where an anesthesia provider can erroneously grab maybe a muscle relaxant or an antibiotic or anything that does not provide hypnosis, mainly thiopental and an antibiotic, maybe cefazole or ceftriaxone. They look similar, and you give someone an antibiotic instead of giving an hypnotic. While the patient is paralyzed, and the patients will have no pain, no movement, but it will be aware of all the things. While 16% of the patients, among them, the awareness incident had no obvious cause. Let's go a little bit deeper in the details on the cause or contributing things of the awareness. We can group them into 4 major groups. The first one being problems with patient dose requirement variability. The second one being problems tolerating side effects of anesthetic agents. I will come in details soon on next slides. Problems detecting the clinical signs of awareness or right anesthesia, as well as problems with equipment and drug delivery mechanisms. Let's detail each point. Let's start on the patient dose variability. Naturally, there is a pharmacogenetic alteration where we see polymorphism, pharmacological polymorphism among individuals. Here I want to mean that different people tend to respond differently from the same dose of anesthetic, from their genetics as well as the response of the drug to the receptors. We can have unexpected patient-specific variability in dose requirement. Like this may take place, especially when the preoperative assessment was maybe not deep, or they missed something in among the risk factors that can predispose the patient to need a much anesthesia. For example, chronic alcohol abuse, smokers, chronic drug abuse, of course, a young age group, anxious patient, as well as other patients who may be on drug that induce hepatic microsomal enzymes. They tend to need a bigger dose of anesthetic if an anesthesia provider did not take into consideration all those patient characters, may end up giving a usual dose while the patient is needing a significantly or relatively higher dose, and this can predispose to awareness under anesthesia. When it comes to problems of tolerating side effect of anesthetic agents, it is well known that general anesthesia may cause cardiovascular depression by decreasing systemic vascular resistance, as well as myocardial depression, like a direct myocardial depression. As a result, there are certain types of surgery during which anesthetic doses may be deliberately reduced in the interest of safety in order to maintain blood pressure. We need to balance pros and cons. Of course, initiate the vasopressor to treat the hypotension rather than awakening the patient, but it comes like at some points during the procedure, the patient tends to have hypotension, and the anesthesia providers are trying to decrease the inhalational anesthesia to keep a stable hemodynamics. That's what I wanted to mean. These typically include cardiac surgeries, emergency or trauma surgeries, as well as cesarean sections. Those are surgeries, emergency surgeries. Those are surgeries in which we need to do maybe rapid sequence inductions and can even have a difficult airway. So in that particular points, the patient may experience awareness of the events. So in the absence of course, there is also problems. There may happen problems detecting the clinical signs of awareness of right anesthesia. This is another big group where the patient may have awareness, but it's difficult to recognize that. Of course, in absence of specific depth of anesthesia monitoring, of course, here I want to focus on developing countries where there are no there are resource limitation, where there is no proper monitoring of the depth of anesthesia with the inhalational gas monitors, maybe like bispectral index or auditory evoked potentials. And in that particular settings, they usually see the cardiovascular parameters and rely upon them. Like if they say the patient is having tachycardia and hypertension, they say tachycardia and hypertension may be other signs of sympathetic stimulation like sweating, lacrimation, or even mydriasis. They may rely on these things. But there are some factors that can blunt this and can be difficult to recognize. Those are, for example, anticholinergic medication that may dry secretions and reduce sweating and lacrimation, and the patient may have awareness, and you can't really find tears or even sweat. There are many antihypertensive drugs and the anti-anginal medication that may reduce the patient's ability to mount tachycardia and hypertensive response to stress. Those are, for example, beta blockers, calcium channel blockers, angiotensin converting enzyme inhibitors. Can give an example of drugs like clonidine and dexmedetomidine, as well as epidural. Can do a procedure where you can combine general anesthesia and epidural, and a hypotensive response from sympathectomy may have hypotension. Depending on the level, you can even have hypotension, and you can say maybe this patient is not having awareness anesthesia under anesthesia. A few disease conditions may also cause a similar uncertainty, like those patients with endocrine disorders, mainly diabetes with the autonomic dysfunction. They may not have ability to mount tachycardia, hypothyroidism, and limited cardiac reserve, especially in elderly. As you know, they have poor response to poor ability to maybe not really likely to mount tachycardia as young subjects. Okay, let's go to the next slide. Can you hear me? Okay.
Of course, yes.
Okay, let's go to another big blood group where the problems are so much. The risk factors, of course, a critically ill patients, if you can say, American Society of Anesthesia, more than class 3 and more. Those patients are afraid, and the anesthesia provider tend to be cautious, giving titrated doses of anesthesia. And these particular patients tend to have some episode of awareness. Age greater than 60, where the patients have decreased cardiac reserve. They have limited ability to mount hypertension and tachycardia. It's a hypertensive autonomic response to stress. Total intravenous anesthesia is another risk, greater risk compared to inhalational. Of course, a long duration of surgery. Where the patients will tend to have some hemodynamic instability, and the adjustment of their inhalational as to maintain a good hemodynamics. A patient who is a drug and alcohol abusers tend to have cross tolerance of the medication, and they tend to require a bigger dose of hypnotics as well as other medication. Pregnant people, because of the increased cardiac output, it takes a little bit longer for the inhalational anesthesia to meet the minimum the mark to equilibration of the lung and the brain. It takes a little bit longer. Anxious patients will need a little bit higher dose. So, and any history of awareness is a risk factor. And how the patient perceives awareness under anesthesia. Most of the patients will recognize sounds and conversations at 89 to 100%. Sensation of paralysis or strangulation at 5%, anxiety and panic. The rest common is visual perception, sensation of endotracheal tube in situ, and the sensation of the operation without pain. So those are the consequences. To the anesthesia provider, of course, there may be some penalties, courts, fines, and so on. But to the patient, let's focus on this. Patient may have sleep disturbance, nightmares, anxiety and panic, flashbacks and depression, avoidance of medical care, as well as post-traumatic stress disorder, which is a little bit which is common, 12 to 20%, and this is added to the patient when it happens. So prevention of awareness under anesthesia is subdivided again in 4 main things. We have to do a thorough or a proper pre-op evaluation. Of course, history, physical exam, paramedical investigation, and identify patients at risk. If possible, we can even do some education to those patients about possibility of intraoperative awareness. Prior to induction of general anesthesia, we need to check the function of anesthesia equipments. Of course, premedication of benzodiazepine will help in a antegrad amnesia and will minimize the risk. This has proven to decrease the risk of awareness. There are some intraoperative interventions that will prevent awareness. It's a cautious use of neuromuscular blockers. Here, if we go back in the history of anesthesia, prior to the discovery of neuromuscular blocking agents, the opioids and the hypnotic were used a little in a big amount. But with the use of neuromuscular blockers, anesthesia providers tend to decrease the dose of hypnotics. I know anesthesia providers in this webinar know much about this, and this is to be used cautiously when needed, on maybe if I can say when needed, of course, is a proper dose. Of course, intraoperatively, we need to use monitored anesthesia care, where we needed to, minimal alveolar concentration should be greater than 6.7 or 0.8, where we have gas monitors. In a good setting where we have bispectral index, we'll use it if we have a value greater than 60. We are sure that the probability of recall is less, but it's not zero. Postoperative intervention, we need to, whenever possible, we need to ask. Let's postoperative interview to report awareness. If awareness is recognized, we need a proper counseling and psychological support. Management is easy if it's still in a short-term memory. As soon as accident awareness is discovered or suspected, we need to deepen anesthesia with either hypnotic available, preferentially a short-acting benzodiazepine or other hypnotic, will prevent the conversion of short-term memory to long-term memory, and be prepared for post-operative patient interview, counseling, and psychological support, because patient may wake up with a recall of those events, either explicitly or implicitly, maybe knowing exactly what happened or may have some behavior change. So we need to really closely follow up this patient because he or she is at high risk. Like a take-home message, selection of inadequate anesthetic dose plus resistance to anesthetics may give maybe a smaller dose, may give an adequate, a deemed adequate dose, but the patient may have a resistance to anesthetic. We may even have malfunction of anesthesia delivery system or total intravenous delivery system, and then this will give inadequate hypnosis. Of course, this patient will be paralyzed or not, and then the patient will have a recall of this or these events. This may lead to a patient to end up consulting departments of psychiatry for post-traumatic stress disorder. I used this short image as a take-home message. This is close to the end of the session. This is the answer to the provided multiple choice question. Of course, trauma cases, surgery with trauma patients is at high risk of awareness. I would like to hear from the audience your questions, comments, of course. Thanking
All right.
you.
Thank you, Dr. Justin. I think everyone here can appreciate the presentation. It was well structured and well presented. So really appreciate your work, Dr. Justin.
Thank you so much, Daniel.
All right.
And
So
Tim.
all right, now we can start this part of questions. So in the comment section, we have some question that was asked there. So let's start from the questions from the comment section. The first question that I asked there was asked by YS Rhoda. So she's wondering, like, are there some alarming signs that can tell anesthesia provider that the patient is experiencing awareness? If yes, what are those? And she was asking because most of the time the situation is known post-op, or like when the patient is up and start to say that he was experiencing anesthesia awareness. Then when the patient is telling you the story about the experience he had in operation. And so, doctor, would you mind starting with this question and address it before we go on with the other question? Thank you.
Yeah. Thank you so much, Loda, for the question. There is, of course, there is some alarming, there are some clinical signs that can be a hint that the patient may be experiencing awareness. We can start from physical findings. Awareness can be manifested by signs of stress response or sympathetic stimulation, like tachycardia. On the cardiovascular side, you can have tachycardia, you can have hypertension. Of course, we can have a lacrimation. Lacrimation can arise from both pain and awareness. We can have mydriasis. Those are like the physical findings we can see on the patients. On the monitors, where we have, we can have special monitors, like there is a monitor we usually don't have a locally. I don't know if maybe some developed countries in Africa may have it, maybe South Africa, but BIS or bispectral index, it's like a sophisticated monitor where we put electrodes on the forehead of the patients, so that we can, if we have a BIS of 60%, we say the probability of recall is low. But if we start having a BIS of less than 60, we say this patient is likely to have the recall during the procedure. However, it's still challenging because some patients can have maybe a disease condition that may prevent stress response to stress, like a patient with beta blockers, AC inhibitors, calcium channel blockers, or a patient with autonomic neuropathy or cardiac, a patient with hypothyroidism. All these patients tend to, as well as elder patients, all these patients may have awareness under anesthesia, but they are not able to mount tachycardia, hypertension, and patients under anticholinergic may not be able to show up significant amount of tears and sweat because anticholinergic have dried up all the secretions. So I don't know if Loda is satisfied. However, comments are welcome. Thank you.
Thank you again, Justin, for the response. We still have some questions in the comment section. Another question was asked by Chibuzo Odega. So he was saying he was appreciating your presentation, but you mentioned the patient would have awareness without pain. But what of when the patient is paralyzed and can can still have without pain? So when the patient is paralyzed and can still feel the pain during the surgery, what is this called? How do we call it? Like a patient is paralyzed but can still feel pain. So Chibuzo is wondering how do we call? So the floor is yours, doctor.
Okay, thank you so much for this question. When of course, the anesthesia, a general anesthesia is having a triad of hypnosis, maybe amnesia. We have to provide amnesia, which is to make the patient not aware of all the events of the procedure. If the patient did not get amnesia, can recall some event. This is termed awareness under anesthesia. When the patient is paralyzed, maybe I'm having adequate amnesia, but is feeling pain. This is inadequate pain control. If I can call it inadequate pain control or analgesia. There is no specific term for this one. It's inadequate analgesia.
All right, thank you.
Control the pain.
The next question is asked by Rafael. He was wondering, he would like to know the trend of using BIS for the intraoperative use across different hospitals in Africa. So do you have any idea about this? If you have, you can give us some insight about it.
Thank you, Raphael. I hope Raphael is probably talking from out of Africa.
He's probably from Ethiopia.
All right.
So you have mentioned this during your presentation that some countries are using it. You mentioned about South Africa. So he's just wondering if you have like a trend, a trend about it, about how it is being used across.
Yeah, that's a good question. I really don't have exact data, but I can extrapolate. Locally in Rwanda, we don't have bispectral index. I guess as well as other developing countries. I have seen that once I was in rotation in Canada. I think these are monitors that are mostly found in a resource-stable countries, but they are helpful during the procedure. But I hope in Africa it's not really available in majority of countries. Rare country. I was guessing South Africa. I'm not even sure, but I guess South Africa may use it.
All right. Thank you for your response. Erinara also is wondering, he first appreciated your presentation and was asking, what about wake-up test patient? How often in your practice they remember awareness during that?
Okay. Thank you for the question. Wake-up test is a test that we perform, especially in back surgeries. When we, for example, let's take an example in a Rwandan context, like we are doing back surgeries. Ideally, we should be using motor evoked potentials as well as somatosensory evoked potentials to see if the lower limbs are really working well, no iatrogenic nerve impairment. Because some resource-limited settings don't have somatosensory evoked potential and motor evoked potentials, we use a wake-up test where we try to wake up the patient up so that we can see that the lower limbs are still functional. After this, we deepen the anesthesia again. And that particular event, the patient at that point has recorded the event, but it's still in the short-term memory. With deepening of the anesthesia with of course deepening of hypnotics, most of the patients theoretically do not develop long-term memory. So I hope the recall here will be about it's like about 1% in the paper that I've seen, but they were advising the use of hypnotic later to deepen anesthesia and probably avoid the structural changes that transforms short-term memory into long-term memories. Thank you.
All right, thank you, Justin. There is, I hope he's answered that from your practice, it is about 1% of the patient. So Alefa also is wondering if you have any report about anesthesia awareness in a pediatric patient. If understand well, is that 1% like from adult patient or also including the pediatric? So he's wondering if you do have also some data from the pediatric patient. Thank you.
Okay, thank you so much for the question. The intraoperative awareness in a pediatric patient is really uncertain and difficult to do because of the characteristic of kids. For example, maybe another, maybe a schooler and adolescent, but it's really hard to know the intraoperative awareness for younger kids. So I didn't pass across that particular paper with exact data.
Okay, thank you, Justin. Unisa is asking, is it advisable to repeat a patient dose of anesthesia, spine anesthesia, after first dose fails? And if so, what would be the adverse effect to the patient recovery?
Come again?
Unisa is asking, is it advisable to repeat the patient dose of anesthesia, especially spine anesthesia, then after first dose fail? And he's asking if it is advisable, what is the effect, the adverse effect for the patient recovery?
Yeah. Thank you for the question. If I caught well what he wanted to mean, it's like we give spinal anesthesia, it fails, and then another option is either to redo a spinal or to do a general anesthesia. If I try to put this in line of the presentation, when the spinal anesthesia has failed and you have a normal, if you decided to go to general anesthesia, you have to bear in your mind that the patient will have both the effects of the spinal, which is sympathectomy from spinal anesthesia, which will be added to the hypotensive effects of general anesthesia. The advice to me is to be ready to give it's like a cardiovascular support with inotrope and vasopressors, but give adequate dose of hypnotics and analgesia, because the patient may, if you give a subhypnotic dose, which is mentioned among the causes of awareness, we tend to give subhypnotic dose to maintain hemodynamics of the patient. In that particular situation, we need to give a titrated dose of anesthetic, but a proper dose, but also support hemodynamics with inotrope and I mean vasopressors. So for the recovery of the patient, of course, the patient may have a delayed recovery if he has some hypotension and acidosis. But my advice is to give adequate dose of hypnotics and then support the patient with inotrope and vasopressors. Thank you so much.
Thank you, Justin. So Ahmed is asking, how can we diagnose intraoperative awareness? And what will be our subsequent plan to be done for this patient? And Dr. Justin, would you mind if you try to be faster, be quick in answering questions because time is running? So right. Ahmed is asking, like, how shall we diagnose it, and what will be the plan for this patient?
There is a questionnaire that we usually give the patients, asking like, what the event do you recall during the procedure? It's like it's a clinical diagnosis. There is no paramedical investigation for that, no imaging. It's a clinical diagnosis. We need to make sure it's not a dream during the operation, and when it is highly suspected, we need to give counseling and psychological support in a specific department, namely psychiatry department. Thank you.
All right, Justin. So Rachel is appreciating your presentation, and she's saying sometime in attempt to reduce wake up or recovery time, at her side, they tend to reduce a dose of anesthesia a few minutes at the end of the surgery. Now, to what length of time do we need to prevent awareness under anesthesia?
I don't know which country she's talking from, but the advice is to, for example, if we have a long procedure where you have used the maybe hypnotics, maybe a inhalation anesthesia, when you cut the long-acting hypnotics, for example, a gas, you need to keep some short-acting, reinjection of short-acting hypnotics. If I take an example of Canada, can stop inhalation anesthesia and give maybe a small dose of propofol, keep the patient not aware of what is going on, or can give an infusion of dexmedetomidine or anything, but don't need to cut the anesthesia when the procedure is still ongoing. Thank you.
All right, thank you. So Ibrahim is asking like how smoking affect anesthesia drug?
That's a good question. He's asking a good question because the research have proven that smoking, the smokers have hepatic microsomal enzyme induced. Their hepatic microsomal enzymes, mainly the cytochrome enzymes, are induced. So the drugs are metabolized a little bit faster than others.
All right. The question in the comment sections, now they are done. So we are exceeding the time for questioning, and now let's welcome Dr. Gasto to give us a remark, and I might have also adding something. So Dr. Gasto, are you around?
Hello. Do you
Yes,
hear me?
doctor, you are most welcome, doctor. The floor is yours.
Okay. Thank you very much. I would like to thank and congratulate Dr. Justin for a good presentation. By the way, this presentation, part of anesthesia, is the complex one. And having this first presentation with TORG is really good to start with the hard one, the bony one. Thank you very much. And when he was presenting, was like talking to anesthesiologists, anesthesia providers, and we have people around perioperative team, but it's not anesthesia. But I think the general principles and the important information was provided. So thank you very much, Dr. Justin. So what I can just add is as he has given the groups, the teams that are vulnerable for that, it's better to have it in mind before, because one of the risk factors is inadequate anesthesia and other factors that we have to prevent it. And then the early recognition is a key, and then and after, if the patient has experienced it, you have to be approached afterwards, after surgery. It's just uncommon, but can happen and may cause just PTSDs afterwards, and it's like a long-lasting psychological problems that a patient may experience. Good. So I would really appreciate the participation is really high, like more than 50 people attended from all over the world, and this is really a very good milestone. And thank you so much to join the Rwanda chapter TORG. I really appreciate. And thank you, Danny, for coordinating that. Thank you everyone who attended. I know it's not a good timing, like in the evening, Sunday, everyone is just at home with family, but you managed to come. Thank you very much. Thank you very much. Thank you, Wilson, to coordinate this. And I think we are with Madam President. If she can say something or she just wish to stay behind.
I'm happy.
But
Thank you.
I really appreciate
Thank you so
Yeah,
much.
we can see her behind the logo of TORG, but you're very welcome if you can say something, and then we call it a day. Thank you very much.
Okay, so thank you, everyone. I want to say a million thanks to the Rwanda chapter. Thank you for organizing and for facilitating the session. It was very insightful. And I want to say thank you to everyone who connected from all over the world. I'm sure we missed out on some countries. Sincere apologies for that. I know some people joined they registered very late, so there was no way we could update the flyer. So thank you so much for joining. I want to say that our next webinar would be coming up by next weekend, and that would be hosted by the Pakistan chapter. I think we're going to start sharing that as soon as possible so that everyone can register for that as well. And the next Rwanda chapter webinar will be coming up next month, and we will send the flyer up as well so that everyone can see what's coming. And so thank you, everyone. Good morning, good afternoon, good evening, and good night for those who are about to sleep. And thank you so, so much. And immediately after this webinar, you are going to receive like an automated link for the evaluation, and certification details should be provided in the questions as well. So thank you for connecting, and we'll see you next time. Bye, everyone. Bye, bye, bye.
Bye, bye.
Bye.
Thank you. Bye.